All right. So when I was first invited to give this talk, isn't there another slide? Oh, so when I was first invited to give this talk and I was given this topic, in my mind, I was thinking about radium-223, and I was thinking about all the experience I had giving radium-223, and then using the available data to sort of come up with a story that made sense. That being said, things changed on November 30th when there was an announcement, and we'll go into those details later. But it sort of reminded me of this book, Good to Great, written in 2001. It was published in 2001. And then if you look at the various companies that were actually talked about in the book, it's interesting to see how they perform. So, it's good to great to good, or maybe even gone. Circuit City, wow, if you invested in that company based on that book, you'd be broke. Fannie Mae was delisted from the NYSE. Wells Fargo had their own set of issues with fraud. And these companies during the economic recession actually underperformed the S&P 500 during that time. So it was kind of an eye-opening lesson that, you have to change. And, Jim Collins, being the thought leader that he is, wrote a book, How the Mighty Fall. And I think it's kind of ingenious that he would follow up with that. So I think we all know that change is going to happen. Change is real. And I think one of the great things about this meeting is that we really embrace change, and a lot of discussion about change occurs. I was talking to Jim Salora at dinner last night, and he actually made this comment that coming to this meeting helps him stay 3 years ahead in his practice, which I think is pretty remarkable. Lugpa, now a partner in this meeting, clearly is a change leader, and they've talked about various things. They've made a huge difference, and now with the APMs, I think the urology is in really good hands. So something magical won't happen if we don't do anything. We actually do need to act. And when we think about change, I think clearly technology change is much faster than anything else. And then I think social change occurs next, business change, and political change. When we think about change in medicine, I think it actually lags much lower than anything else, which is a concern, because I think we have a target on our backs, and disruption is real. And if I think about radiology, my field, when I went into radiology, everyone told me, oh, why are you going into radiology? PACS, teleradiology, all your cases are going to be outsourced. And that might have been true, but I think our society embraced the technology and really made it work to our advantage. And artificial intelligence, machine learning, yeah, that's real. But we're taking very active steps to embrace it and use it in ways to actually improve patient care and reduce costs. And I think if we all and urology, same thing. Advanced prostate cancer clinics and the changes that are undergoing in urology have been have really helped us and create a roadmap for ways that we can change from our society's perspective. So that being said, we're going to talk about targeted alpha therapies and radium-223, and this sort of lists out some of the other drugs in that CRPC space. And this is really going back to the future, because these systemic unsealed sources of radiation that were injected were actually used in the past, but we're revisiting them, and I think there's a lot of potential for these in the future. So just to review, radium-223 falls in the same column as calcium, the 2+ valence electrons. So it's a calcium mimetic. You inject it intravenously, slow over 1 minute. It circulates throughout the body. And then it's going to localize to bone. It's going to localize to areas that have metastatic disease to a higher degree because there's greater perfusion to those areas, and the surface area of bone in those areas are actually going to be greater. Once it localizes to those lesions in bone, it's actually going to give off this alpha particle and create these double-stranded DNA breaks. And there's actually small animal models that talk about radium-223 causing changes in the tumor microenvironment that make it less hospitable to METs for the future. So this is sort of the real key to how these alpha particles work. The alpha particle, you notice that the particle mass is multiple times greater than beta emitters, which is what we use in a lot of other therapies. So it's like getting hit by Mike Tyson as opposed to Floyd Mayweather, which, by the way, Floyd Mayweather, he's a great boxer, but clearly he doesn't have a lot of power. Its range in tissue is much shorter. So that is significant because the radium is going to stay localized to the areas that it lands, as opposed to beta particles, which are going to go much further and affect healthy marrow cells, which is something you do not want to do. And that's why we see the safety profile that we have seen with radium-223. And that's why we saw this improvement in overall survival from the Alcimco trial. But we also saw an increase in time to your first symptomatic skeletal event. So there was sort of this bone protective aspect to radium-223 as well. So I think, it was approved, 4 or 5 years ago. We're seeing more and more adoption of this. And we're seeing greater acceptance and greater ownership of this. And it was interesting to hear Dr. Crawford, the first talk where he talked that there were actually 54 clinical trials actively using radium-223 on clinicaltrials.gov. So I think that's a sign that we're really trying to dig deeper into how we use this. All right, so let's start the search. And why are we starting the search? I think the search for a combination therapy or a therapy that you use together really makes sense for radium-223 because of the mechanism of action. It localizes the bone, and it's really disease agnostic. It just gives off an alpha particle wherever it can and causes DNA breaks if there are cells there. So it's bone targeted. A problem with radium-223 is that PSA rise, right? So you do see a slow rise in PSA, and we know that's probably coming maybe from other cells, like other tissues, like soft tissues, nodal disease, and whatnot. So it makes sense to find something with a different mechanism of action where you can target various sites of disease. And I think the other reason why it makes sense is because the drug has been proven to be safe in the Alsimca trial. So when we look for some sort of combination therapy, I think ideally you find something that's synergistic, and this comes from a multiple sclerosis website. You know, if it's additive, that's not bad either. You know, in this case, you know, if you have something that's hitting the bone and something that's hitting the soft tissues and they're additive, I think that works as well. Clearly, you don't want something that's antagonistic, in which case you wouldn't move forward with such a therapy. So we'll start off with radium-223 plus targeted therapy. And this morning, you know, hearing Dr. Gloday's talk on PARP inhibitors was great for me because it really opened up my understanding of PARP inhibitors. And there are currently a couple phase 1B and phase 1 and 2 trials looking at PARP inhibitors. And this makes sense. You know, if you have radium-223, these alpha particles that can cause double-stranded DNA breaks, there are going to be times where it only causes single-stranded DNA breaks. And in those cases, if you have the combination with a PARP, it makes sense that, you know, you'll lead to more cell death. So we'll await results from that. But that led me to think, all right, imaging. You know, I think a lot of times we don't really use imaging to assess response, especially in prostate cancer. But this is something that we did for targeted therapies, BRAF and MEK inhibitors in melanoma, where we actually had baseline scans, follow-up scans, and actually looked at response and correlated that with overall survival. So I think the further we go along with these targeted therapies and combination therapies in prostate cancer, I would encourage, you know, some of the scientific people in this audience to think about ways that we can incorporate some of these newer imaging technologies into our protocols. So radium-223 plus immunotherapy. Dr. Concepcion gave a great talk on immunotherapies, and I'll be honest, you know, this whole experience has been very humbling. Medicine has been very humbling, and I remember when I first heard about the abscopal effect, I laughed. I thought, that's impossible. You know, that makes no sense at all. And I just sort of really dismissed it, and it was kind of, you know, shame on me. So we started seeing cases like this, and this case comes from the literature where you had a liver lesion that was treated with external beam radiation, and that liver lesion was gone on a follow-up PET-CT. And interestingly, a lesion in the left lower lobe of the lung disappeared, even though it wasn't radiated, and this lesion in the left sacrum also disappeared. And that's sort of the idea of the abscopal effect. It's a little different because abscopal effect was really meant for targeted therapy to a single lesion that releases antigens, and radium-223 is a little different because it's systemic. But the whole idea is, you know, you have radiation, it releases various inflammatory mediators, cytokines, antigens, and then if you can combine that with something that stimulates the immune response, you could lead to greater targeting and attacking of the cancer cells. So there are several studies looking at this currently. There's a phase 2 trial that was originally scheduled to complete in December of 2018. I think it might be a little delayed from what I hear, but it's going to look at peripheral T-cell proliferation, immune response, safety, PSA alk-phos, radiographic and clinical progression, and time to chemotherapy. So I think this holds a lot of promise to see, when done together, if there's actually an improvement and a synergistic effect to the two, which would be very promising. So then you have the PD1 and PD-L1 inhibitors that are actually being used right now in clinical trials, but those won't be completed for a little later. But it's encouraging to see the use of some of these other more second-generation immunotherapies used in clinical trials with radium-223. But the discussion of radium-223 really brings into, it gives us the opportunity to talk about immunotherapy and radiology. And I think this is something that we've noticed and gave us an opportunity for a former colleague of mine, Jennifer Kwok, to write a great review article about this in Radiographics, because you will see immune-mediated adverse events. And oftentimes they will show up on the scans that you get for follow-up, CT scans. You'll get colitis, which can be life-threatening. You'll get hypophysitis. You can get various things, pancreatitis, just inflammation to normal cells. And it's important to recognize that these aren't signs of disease progression. It's just actually the drug working. And in fact, there was a study published in the American Journal of Radiology that talked that the greater number of immune-mediated adverse events you had on imaging, the better the response was clinically. So I think it's something to be aware of. Also, the patterns of immunotherapy on imaging are different. So oftentimes, things will look stable before they get better, or things could potentially look worse before they get better. So be careful if you see something that talks about progression, especially if it's a single time point. So one thing that we always request is we don't request it since we're on the same EMR, but we look through the medical record, we look when they started immunotherapy, because that will have a huge impact as to how we interpret those images. So for those of you practicing, make sure that you have a good working relationship with your radiology team so they understand that. All right, so radium-223 plus chemotherapy. This was one area that I really sort of was incredulous, and I didn't think this would be successful. But so far the preliminary data shows that it could be safe, and maybe it has some efficacy. So phase 1/2A trial had 5 doses of radium at 50 kilobecquerels. I think right now it's 55 kilobecquerels every 6 weeks in combination with a reduced dose of docetaxel. And this was administered intravenously every 3 weeks. This was from, I forget, GU ASCO maybe a year or two ago. I think 2 or 3 years ago, talked about the safety profile, that it was actually safe. And they saw a response in total alk phos and P1MP, which is a bone turnover marker. So again, I think this actually holds some promise, and phase 3 trials I think are currently in development looking at metastatic castration-sensitive prostate cancer, and those patients will get hormones, docetaxel and radium versus hormones and docetaxel, and also in CRPC where they'll get docetaxel versus docetaxel plus radium. So radium-223 plus AR inhibitors, this was sort of the low-hanging fruit, and I think most people would agree when we were thinking about this years ago, this was sort of the easiest hurdle to overcome, and this was probably the first combination that would be approved. This comes from the expanded access trial. Fred Saad published this et al. In Lancet Oncology in 2016. This, I think, included maybe 800 patients that actually showed that it was safe in patients who actually received abiraterone, enzalutamide, and denosumab with radium-223. And not only did they find that it was safe, they actually saw some findings that suggested a prolonged survival in those patients that actually received Abi, Enza, and denosumab with the radium-223. And this was designed similar to Alcimca, where patients were given radium and kept on their normal standard of care therapy. In Alcimca, I don't believe any patients received Abi or Enza. So there's Eradicate, and this comes from Dr. Shore, open label phase 2 trial. I think it might have been 30, 40 patients. Patients were given radium plus Abi and prednisone. And this was CRP patients with symptomatic bone mets. And they looked at bone pain and quality of life. And they also reported that it was safe. The pain severity score decreased in 35%. 18 out of 31 had a greater than 30% reduction in pain. And 12 of 31 patients had clinically meaningful palliation of pain. So good results here with regards to quality of life and pain, and also safety. So November 30th, we'll talk about ARROW-223. So this was a randomized, double-blind, placebo-controlled, multinational, multi-center phase 3 study that's examining patients with CRPC with bone mets. And the patients were asymptomatic or mildly symptomatic. They were chemo-naive, and it included roughly 800 patients. And they were randomized in the 1-to-1 ratio to either radium plus Abi and prednisone versus placebo and Abi and prednisone. So November 30th, 2017, I think I was in Chicago for RSNA, this red box warning comes out. The Independent Data Monitoring Committee reported an increased incidence of deaths and fractures, and they required that the study be unblinded. So there's very limited information, but they did report that the incidence of fractures was 24% in the treated arm versus 7% in the placebo arm, and deaths were 27% versus 20%. So the full analysis isn't complete, and I don't think we'll see the data from that for at least a few months. but the current recommendations are not to treat anyone with radium plus abiraterone, and for those that were treated, to follow them closely. Interestingly, all of the doses of radium were actually completed much earlier, so this was during the follow-up phase. They also did announce that there was some preliminary evidence that indicated that denosumab or bisphosphonates may minimize the risk of fractures. But again, that's all we have, and we don't have more data on that. In that study, the patients were stratified based on geography and their use of denosumab or bisphosphonates and total alk phos. So it'll be interesting to see that data to see if geography played a role in some of this, and also to see how denosumab and these bone protective agents actually helped. So failure is success if we learn from it, and I think that's true. And we've seen a lot of quotes about failure all the time, and I think we can't take failure as a reason to stop trying or just totally pivot 180 degrees. And Chuck Ryan wrote an interesting blog post on Euro Today recently about this trial and talking about equating it to the Apollo 13 mission. And for those of you familiar with that, it went up. The mission was to land on the moon. There was an explosion due to an oxygen tank that exploded because of an uncovered wire. Obviously that's catastrophic when you're in space, but they actually figured out a way to get back to Earth safely. So that was a successful failure. So I think this sort of just puts things in perspective that we shouldn't overreact. I think we need to look at things carefully. And we need access to that data to really dissect what are the areas that went wrong and what is it telling us. And that's why we do these clinical trials and that's why we need access to this data to really see where we go from here. But in the meantime, I think it's kind of fun to hypothesize with regards to why this might have happened. When I talk about it with Neil and Dave and various other people, I think one possible hypothesis is that maybe there's a flare response. We do know there's a flare response with abiraterone. So in the phase 3 trial looking at Abi and prednisone, there was a flare response, and they saw discordant bone scans in 12 of 23 patients. So discordant in the fact that the bone scans looked worse, but the PSA went down greater than 50%. And those bone scans that looked worse, 80% of those scans actually improved on follow-up. So flare was seen in 43% of responding patients. And this goes back to Dr. Reiter's point that bone scans aren't very good, yet we incorporate them into all of our clinical trials. So this is an example of flare published in 2016, but again, we've seen this for years. But you take a case at baseline, and you look at them at 3 months, and you look at them at 6 months, and you see a sternal lesion that'll look hotter, a little worse at that 3-month scan, and it sort of stabilizes. And again, oftentimes you see this, especially in breast cancer patients, that they have osteolytic disease. They often get treated, the bone scans look terrible, and they stabilize or look better. And again, that's most likely a bony reparative response to these lesions being treated. Radium-223, we're learning more about radium-223 and how it works and how it reacts on imaging. And there was a recent study published in 2017 that talks about bone flare. And that bone flare is pain flare and a radiological flare. So bone pain increased in 27% of those patients. It decreased in 49%. And they saw an increased number of lesions in 26%. And 74% were stable at 3 months. So the big question is, maybe there's a difference between combination versus layering. So if you look at the expanded access trial, you look at Neil's Eradicate trial, maybe the difference here is combination versus layering. In ERA-223, these patients were started on abiraterone with radium-223 within a 3-day window simultaneously. In Eradicate, 1/3 of patients, I believe, were started on abiraterone at least a month before, and 2/3 of the patients were actually started on Abi at least 60 days before they were started on radium. So again, maybe that's one of the differences. Maybe you sort of clear that flare response in the beginning, and then you add the radium, and that's why we're seeing that those improved survival rates when it's layered as opposed to combination. Again, we don't know this for sure, but just kind of fun to speculate. Peace 3 is another trial. It's a randomized multi-center phase 3 trial comparing ENZA versus plus radium-223, very similar to the ERA-223 trial. So that'll be interesting to see what that reports, and that is scheduled to be completed in November 2019. So quickly, conclusions. When this quote first went up or was mentioned years ago, it was confusing, and I know a lot of us laughed. But the more you think about it, actually, it kind of makes a lot of sense. And there are known knowns. These are things we know that we know. There are known unknowns. That is to say, there are things that we know that we don't know. But there are also unknown unknowns. There are things we don't know, which that's mind-boggling, right? And it actually makes a lot of sense. And every day I'm reminded that there are so many things that I don't know, and it's kind of it makes life a little more interesting. So kudos to Donald Rumsfeld for being able to articulate that on the spot. So anyway, Radium 223. I think the personal ad is still out. Enjoy bone-seeking journeys and long walks on hydroxyapatite crystals. I help patients live longer while promoting safety. I'm seeking a like-minded partner who likes bone as well, but ideally could treat soft tissues as well, because that would be a marriage made in heaven. And yeah, I like that there as well. So all right. So it's to be continued, and we could do this or skip it. And I think that's it. All right. Thank you for your time.